Hello, welcome to our presentation. This is a case report about a patient with Hermansky-Pudlak Syndrome Subtype 5. We are going to be talking about the safety of cardiac catheterization in patients with a bleeding diathesis. HPS, short for Hermansky-Pudlak Syndrome, is a rare autosomal recessive disease caused by several mutations. It occurs in 1 in a million individuals, but occurs in greater frequency in Puerto Rico. There are 8 subtypes, but common manifestations include nystagmus, light skin, light hair color, prolonged bleeding after minor procedures, which will be very important to our case report, pulmonary fibrosis, colitis, and neutropenia. Subtypes 1 and 3 are those most commonly found in patients of Puerto Rican descent. Diagnosis is usually obtained by clinical presentation and platelet electron microscopy using whole mount technique. This was a middle-aged Puerto Rican-born male with past medical history of diabetes, hypertension, and HPS subtype 5, who presented to the ED with acute sternal chest pain radiating to his left shoulder and hand. He had shortness of breath, palpitations, diaphoresis, and nausea. His vitals were significant for tachycardia to 113 in the ED. His labs were remarkable for a negative troponin and a normal platelet count. This is important because people with HPS have a prolonged bleeding time as a result of platelet dysfunction. Important history related to our patient in terms of his HPS. He was confirmed to have HPS at age 16 after bleeding complications, including red blood cell transfusion following a surgical removal of a cystic hygroma. He's also required platelet transfusions following a wisdom tooth removal and platelet transfusion following tonsillectomy. He's had recurrent hemarthroses into his hip between ages 8 and 15. He's had recurrent epistaxis and prolonged bleeding with flossing. As a result of his condition, he's been legally blind since age 18 and has had horizontal nystagmus since childhood. He also has a cousin with HPS. After full workup, he was admitted for unstable angina and managed per hospital protocol. The cardiology team recommended cardiac catheterization, which did not require stenting. There were no complications. There was negligible blood loss, and he was discharged the next day. So this is the only patient we could find in the literature who was evaluated for safety of cardiac catheterization in the setting of HPS. Our patient was able to receive cardiac catheterization without complications. It is important to recognize the potential for catastrophic bleeding in these patients, and each subtype comes with a different risk of bleeding. As with this patient, other HPS patients have suffered from bleeding complications after relatively minor surgical procedures, including tooth extractions, septoplasty, and mammoplasties, and have required RBC transfusion, platelet transfusion, or administration of FFP. On the other hand, major surgeries, including bilateral lung transplants and other major surgeries, have been successfully performed, as long as they are carefully monitored. So the risk of bleeding complications during cardiac cath in a patient with HPS has never been investigated to our knowledge, but our patient did not have complications. Still, we advise that any patient with HPS should be aware of the risks and benefits of any procedure. HPS should be on any diagnostician's radar for a patient of Puerto Rican descent with a bleeding diathesis. Other clues a physician can use to diagnose HPS are albinism, nystagmus, pulmonary fibrosis, and colitis, and suspicions can be confirmed by genetic testing. We recommend that suspicion for HPS should warrant genetic confirmation so that patients may be aware of their subtype and relative risks of bleeding and other long-term complications. That was our presentation. Thank you for listening.